Okay, we're back. And let's see. Okay, this is where we left off with the different sizes and shapes and what that MCV, MCH, and then MCHC. And here is another diagram. An important component in CBC are all of these. It tells us basically the main thing that we want to know about the red cell is the hemoglobin. And so there it is. MCH means cell hemoglobin. MCHC is the mean cell hemoglobin concentration, and that's where the hematocrit comes in, is the percentages of red blood cells. And then MCV is the mean cell volume. It's basically part of the size of the red cell. MCH is the amount of the hemoglobin in the red blood cell, and MCHC measures the amount of hemoglobin in the average red blood cell, but it also has to do with the percentage of hematocrit that's accompanying that. And of course, these are very, very important in diagnosing blood diseases. In anemia, the red blood cells may be too large, macrocytic. They're macro, meaning large. Normal size would be normocytic, or too small would be microcytic. Diseased red blood cells may have a normal amount of hemoglobin in the cell or too little hemoglobin. And I did bold it at the bottom. I do want you to know as we're going on, don't get too confused, and don't worry about any of these numbers up here. You don't have to remember that. That will be on the CBC. I just want you to know what it means. But there is no such thing as a red cell with too much hemoglobin. We worry only about the lack of it, not too much. And then going on with our red blood cell indices, we need to move on to what is an RDW. And it's the red blood cell distribution. It measures the red blood cell size and variability. Normally, most red cells are equal in size. Most. Variability helps in diagnosing certain types of anemia. Iron deficiency anemia will have very small cells, a varying size, microcytic, because it's deficient in iron. But yet, vitamin B12, and it's a deficiency also, we're very deficient in vitamin B12, but they're macrocytic. They're very large cells. And there it is. RDW is often used to differentiate an anemia of mixed origin from anemia to a single cause. Just to talk a little bit about some of these, iron deficiency anemia is the most common anemia worldwide, and it's usually due to bleeding. And then vitamin B12, we had a really, really good presentation on it in class. And the students that have already done this absolutely know about that. This really isn't to do with the blood system. It has to do with, this is one of the deficiencies in our GI tract. It's found in some foods. Our body needs this nutrient to make healthy red blood cells and also to keep the nervous system working properly. And just put it in the back of your head that all the vitamin Bs, they're good for nerve health, or help our nerves. But what happens here is the person cannot absorb enough of the vitamin B12 from food because they lack the intrinsic factor, which is a protein made in the stomach. So again, this goes back to the GI tract, not due to bleeding like iron deficiency anemia is. So they lack this intrinsic factor, and it leads to a B12 deficiency for vitamin B12 anemia. And then we'll just, again, it's a complex after reviewing some of that. Some of it was new with iron deficiency, and then the red blood cell indices and how what they're indicative of. But what I want to tell you is anemia defined. It's a reduction in the total number of erythrocytes. So it's a reduction in the total number of erythrocytes in the circulating blood or in the quality or quantity of hemoglobin. So it doesn't have to be both. I'm going to say that again. It's a reduction in the total number of erythrocytes in the circulating blood or in the quality or quantity of hemoglobin. It can be due to impaired erythrocyte production, so they're just not being made right, the red blood cells. It can be due to acute or chronic blood loss. It can be due to an increased erythrocyte destruction. So maybe we have the normal amount, but for whatever reason, severe and rapid, or maybe not so rapid, slow hemolysis is going on. So they're breaking down. Or it can be a combination of any of those. And so anemia, it's complex signs and symptoms characterized by, again, decrease in numbers of red blood cells or in the hemoglobin content caused by blood loss, deficient erythropoiesis, excessive hemolysis or breakdown, or a combination of any of those. It occurs when the insult is severe enough to disturb normal homeostatic mechanism and exceeds reserves. So in our big picture of anemia we know is failed production, blood leaks, or the red cell life is shortened. Failed production, not enough cells are added to replace the natural loss or red cells. They don't contain enough hemoglobin through blood loss or destruction through hemolysis. Natural removal, and that's that term apoptosis that we know. Dead red blood cells are filtered out by the spleen at about 120 days. Sometimes they'll say 80 to 120 days. But if it's before that and exceeds what it's supposed to, it's the term hemolysis. Impaired production are conditions needed for red blood cell formation. We know we need the functional erythropoietin. We need that hormone mechanism going on from the kidney. And you can read there, 90% is produced in the kidney, 10% in the liver. So if we have kidney damage and liver damage, we're in a lot of trouble with anemia. Erythropoietin source production stimulated during hypoxia. And normal rate, you don't have to know these numbers. I just threw it in there so that you heard it. 2.5 million erythrocytes per second can increase to 17 million per second under anemia or low oxygen condition. Supplies diminished in renal failure, Epigen given to dialysis patient, Procrit given to non-dialysis patients, and it's just in the mechanism of the medications. We also have a problem with red blood cell formation if we've got uncompromised DNA synthesis. Synthesis impaired in the presence of chronic inflammation or infection, autoimmune disorders such as lupus, that's systemic lupus erythematosus, is SLE, and rheumatoid arthritis. In rheumatoid arthritis and similar in lupus, iron utilization is impaired with decreased serum iron and transferrin concentrations and an increased synthesis of ferritin. There is increased lactoferrin, which binds and lowers serum iron. So basically, we need that serum iron and transferrin, and it's a diminished amount. And so what happens is we have reduced erythropoietin levels, decreased bone marrow response to erythropoietin, premature destruction of red blood cells, and then the red blood cell lifespan may be even reduced in these diseases. So also under impaired production, hemoglobin synthesis is impaired by lack of iron and vitamins, and we already talked about iron, vitamin B12, and folic acid. We have to have adequate absorption, even if we do have these produced. Dietary iron absorbed in the duodenum and proximal jejunum. Some goes directly to the blood, picked up by transferrin, and delivered to the erythroblasts in the bone marrow. So if we have problems with transferrin, and we do in lupus and rheumatoid arthritis, we're going to have problems with hemoglobin synthesis. And again, very little amount is stored in the liver, but some is. Intact marrow microenvironment can be revealed in the production of our reticulocytes, and those are our young red blood cells. Remember, the retic count is about the blasts that retain residual RNA. The retic count reflects the ability of the bone marrow to produce red blood cells. Anticipated response to anemia will be a reticulocytosis, meaning it's breaking it up. Absence of reticulocytosis or presence of penia is inadequate bone marrow response, meaning if we have erythrocytopenia, the bone marrow can't seem to be picking up. So is the problem in the erythropoietin, or is it the problem with the kidney, or is it the problem that the bone marrow can't produce it? So again, many different reasons as to why somebody is anemic. Can monitor the response to treatment. giving someone iron to someone with an iron deficient anemia condition and just see if they get better. Blood loss for causes of anemia. Number one cause, again, is iron deficiency anemia. Can be from heavy periods for a woman, or menorrhagia, or slow chronic blood loss as seen in a neoplasm, any cancer, anywhere that's causing a problem with the blood system, or a GI bleed. Acute from hemorrhage. Adult has to basically lose greater than a liter before a drop in hemoglobin. Young healthy adult may be asymptomatic when laying flat, even when they've lost 1,500 cc's of blood. So there you go. That's that marvelous, wonderful capacity we have of what was I going to say? Compensation. Chronic from erosive gastritis, again, heavy menses, GI malignancies, usually from the bowel. Iron from red blood cell wasted via blood loss cannot be recycled. The normal blood, as you're looking at this, would be the one in the middle, normal blood. You can kind of see that there. The one in the bottom shows small, pale red blood cells. They're much smaller, and you see how much there's hardly any red in there. They would be pale, meaning lack of hemoglobin. Anemia of hemorrhage. Hemorrhage creates two problems: the loss of the oxygen carrying capacity and loss of iron. If bleeding is limited, red blood cells will be replaced in a few weeks. However, if it continues for a long time, again, undetected colon cancer can go on for months, almost years before people really understand that they're sick. The patient can become iron deficient. Iron deficiency in turn hinders the bone marrow to make hemoglobin, and then we have iron deficiency anemia. And you can see they would be very small, pale red blood cells. In iron deficiency, the bone marrow has the capacity to produce red cells, but it cannot produce enough hemoglobin for each cell. Iron deficiency anemia results in small red blood cells, so there'd be a low MCV, and then they're pale, so it'd be a low MCHC. And let's go back to see what those mean. MCV is mean cell volume, usually measured by red blood cells times 10, so we're lacking them. They're going to be small. It has to do with the size. MCH means hemoglobin, mean cell hemoglobin, and because we're missing the cells, we're going to be missing the hemoglobin. They usually go hand in hand. Impaired production. So another cause of anemia would be reduced red blood cell production. Nutritional, vitamin B12, folic acid, and iron are the basic culprits. Anemia of chronic disease can be any type of kidney disorder, any type of kidney disease, AIDS, lupus, rheumatoid arthritis, chronic inflammatory disorders, which basically are lupus and rheumatoid arthritis, acute and chronic hepatitis, malignancies throughout the body, develops 1 to 2 months after disease, normal iron stores, low circulating iron. Second most common anemia seen frequently in the elderly would be reduced red blood cell production, decreased erythrocyte lifespan through phagocytosis occurs early for whatever reason. And again, this is an anemia, so it's not producing like it's supposed to. Ineffective bone marrow response to erythropoietin or altered iron metabolism. Symptoms are milder and fewer than other anemias. Low serum iron, lower normal total iron binding capacity, that's what TIBC is. Normal or high serum ferritin levels, doesn't respond to iron therapy because of dysfunctional transport of iron to the bone marrow. Okay, we're going to stop here and then I will be moving on.